Hello class, today's lecture is on the foot and the ankle. Our objectives today are to display an understanding of the anatomy for the foot and the ankle, discuss biomechanics of the foot and ankle, identify mechanism of injury and signs and symptoms of common ankle pathologies, discuss treatment strategies for ankle pathologies, and lastly we'll look at orthotics and shoe types. So our anatomy, we have multiple joints. The first joint we're going to look at is the talocrural joint. It is formed by an articulation of the trochlea of the talus, so that's this flat part right here, the medial and lateral malleolus. This bony arrangement is often referred to as the ankle mortise. So if you hear that term, you know that it's talking about the talocrural joint. They're used interchangeably. So the axis of motion passes transversely through the body of the talus, resulting in a hinge joint, allowing the ankle to dorsiflex and plantarflex. So that's all the motion we're getting here is dorsiflexion and plantarflexion out of the talocrural joint. Now let's look at the subtalar joint. So this is the articulation between the talus and the calcaneus. This produces a triplanar motion, which is pronation and supination. So this is on the right, you see this is the calcaneus. So we got the medial side of the calcaneus. Excuse me, we have three facets, anterior, middle, and posterior. Of course, you see this posterior facet is obviously where most of the weight bearing is taking place, as it is much larger. Also, you can kind of see and appreciate the angulation that occurs at the calcaneus, how more of the weight's borne laterally instead of medially, and a lot of the structure of the ankle sits over here medially. And so here you see a sagittal view, a cross-cut view. I'm sorry, this is actually a frontal view. So this is the subtalar joint here, your talocrural joint here, and so you see the articular surfaces that occur at the ankle. So the calcaneus and the talus, that's the subtalar joint. So we get pronation and supination out of this. So that's motion occurring in all three planes. Then we have the mid-tarsal joint. So that comes out here where the articulation of the calcaneocuboid and the talonavicular. So the talus and the navicular on the medial side, and then the calcaneocuboid, and where the calcaneus and the cuboids meet laterally. So we have two axes of motions, the oblique and the longitudinal. So you can see from a top view, these two axes, the oblique and the longitudinal here, which is basically running towards the big toe, just medial to the, I'm sorry, that would be lateral to the big toe of the left foot. And then you see how looking from the side view, how the oblique axis is moving from down to up. And then the longitudinal axis is actually, here it looks like it's going to the big toe, but we see it's going up out in space here. So the stability of the mid-tarsal joint is directly related to the position of the subtalar joint as it pronates and supinates during normal motion. Now we got the tarso-metatarsal joint. So this is where the tarsals meet the metatarsals. So it's comprised of the cuboid, the first and second and third cuneiforms, and the bases of the 5 metatarsals. So you can see how those go across the joint there. They move as a unit. They're guided by the position of the mid-tarsal and the subtarsal joints, allowing rotational forces during weight bearing. Provides foot stability by locking the midfoot. This is known as the Lisfranc joint, and we'll talk about a little later in the lecture about Lisfranc injuries. Now the metatarsal phalangeal joints. So this is an articulation of the convex metatarsals and the concave phalanxes. These provide stability of the foot. The first and fifth ray move independently from the other metatarsal bones. The first ray bears the most weight and provides for body propulsion. So we're rolling off of the great toe, and that provides a great deal of our propulsion as we walk or run. The first ray is stabilized by the peroneus longus tendon, so it's wrapping all the way from laterally around medially to the medial side of the foot. And then you notice on here that the first ray extends farther than the fifth ray, so they kind of stair-step down. This is one reason that our foot we tend to have lateral ankle sprains. is because our foot isn't like a box. It tails off there laterally, which allows the foot to rotate in more. So the sesamoid bones are pictured here. So we have two of them at the great toe. So they're embedded in the medial and lateral hallucis brevis muscles. So again, just like the patella is a sesamoid bone that adds leverage to the quadriceps muscle, these sesamoid bones here add leverage to these intrinsic foot muscles to give greater support of the first ray and the great toe. Now let's look at biomechanics. So as the foot advances from a contact phase to mid-stance, the foot goes from being supinated to pronated. So whenever we hit the ground, we're in a supinated position, but then as we go into mid-stance, we pronate. So pronation is not a bad thing. Overpronation is a bad thing in which it is not controlled. But the foot has to pronate and supinate because as it pronates, it becomes a mobile adapter. So this allows us to grip the ground underneath us. So as we walk across a yard on an uneven surface or we go hiking, our foot constantly is adapting and changing to the surface underneath us, and this happens at mid-stance. So this mobile adapter occurs because the oblique and the longitudinal axis becomes parallel. So back to the image that I showed you a minute ago of those two axes, whenever the foot's in arrangement in a position where they're parallel, then it becomes mobile and we can easily adapt. So this is really important for us whenever we accommodate to a changing surface. But then as our foot advances from mid-stance to toe-off, the foot goes from being pronated to now supinated. So in this position it becomes a rigid lever. And this occurs because the oblique and longitudinal axis now cross and they lock that mid-tarsal joint. And so now this rigid lever allows us to have efficient ambulation, and it helps us to conserve energy. So if you have somebody with just a sloppy foot that can't go into that rigid lever position, now all of a sudden they're trying to push off and drive off of a mobile adapter instead of a rigid lever, and they're losing all of their energy, so they can't get an efficient extension off of that great toe. So here's a picture. Sorry, it's a little bit blurry there. So in a neutral position, we see the tarso-metatarsal and the cubonavicular joints. We see how they naturally just cross here. And then, not the cubonavicular, the cubotalar joint. I'm sorry. So we have the oblique here, we have the longitudinal here. So in a neutral position, they're barely crossed. In a supinated position, they're crossing here and here. So that locks that foot in position. And so you see how the foot is a bit supinated there. And then over here, we're into a pronated position. You see how the medial side is now falling forward. And so now these joints unlock and the foot becomes a mobile adapter. Now let's talk about some specific injuries. So you can get ankle fractures of a variety type. We have a similar mechanism as an ankle sprain. So an inversion sprain will likely cause a fracture of the medial malleolus. So as the foot rolls in, we're most likely to break off this part of the medial malleolus here as these two bones crash together. And you see how much farther the fibula drops down here below the tibia. And so that's one reason that we don't evert nearly as much as we invert. And so if we have an eversion sprain, then we're going to likely fracture the fib or the lateral malleolus here. So a displaced fracture will typically be treated with surgery, with an ORIF, so an open reduction internal fixation. So they may put plates in there, they may put some screws in there to mend that bone back together. So often these people will be, especially if they have a tibial fracture that's repaired, they'll be non-weight bearing typically from 4 to 8 weeks. Now a non-displaced fracture is just typically placed into a walking boot, typically on the short end of 4 weeks, assuming that they are they're healing quickly. Sometimes it may be extended out to 6 or 8 weeks. So you can also have what we call a bimalleolar fracture, where both sides here, so you have a fibula and a tibia fracture, so a bimalleolar, medial and lateral malleolus. You can also have a trimalleolar fracture. So in the bimalleolar, basically the bottoms break off, but if you have a trimalleolar, now this posterior malleolus will fracture. So you got the lateral, you got the medial, and then they call this the posterior malleolus. So you'll get a fracture through this line here. And so those pretty much are going to require an ORIF to repair those. And those are typically pretty tough to recover from, pretty tough to rehab. Anytime you get into this articular surface where you're fracturing down into that, that really, and they have to be immobilized, it's really a long recovery for those folks. So if you're wondering whether you ought to take a foot or an ankle injury and refer it to the physician, have them x-ray it. So this is the Ottawa ankle rules. So here you see a lateral view of the ankle. So you have the malleolar zone here and you have the midfoot zone here. So if you have an injury in the malleolar fracture and you have tenderness either at the lower 6-inch or 6 centimeter posterior lateral tip of the lateral malleolus, or the 6 centimeters, can't get off on the metric there. So the posterior edge or the tip of the medial malleolus, the lower 6 centimeters, you want to get an X-ray on those. Also, if they're unable to bear weight or weight bear immediately and then in the ER, then you want to get an X-ray on those. And for the foot, if you have pain or tenderness at the base of the fifth or at the navicular, or if they're unable to bear weight immediately and then in the emergency department, you want to go ahead and get an X-ray. And with the base of the fifth, those are real easy to fracture. I've seen people just plant and cut and fracture those. So you always want to check those out and be mindful. Those are really easy to fracture. Typically you'll get those x-rayed if you see those. Now let's talk about a Mason-New fracture. I'm not sure if you've heard of this one or seen it before. I've had an athlete before that's had one of these. So it is a foot external rotation, which results in that should be proximal fibular fracture. I need to fix that. So you see the fibula is fractured here. You kind of see that spiral. So as the foot is externally rotated, and this typically is very forceful, you get transmission of force through the interosseous membrane. So that's the membrane that's between the tib and the fib. And so it's transmitted proximally and then explodes out just below the fibular head. So you could also have some concomitant injury with this. You may have a deltoid ligament rupture. You could have a medial malleolar fracture or a disruption of the interosseous membrane. So these usually require a stabilization of the ankle mortise, but they always leave this alone up here on the proximal, so they don't do anything. They let that line up by itself once they stabilize the ankle mortise. And these are, you could call them a high ankle sprain. They are, but they're a little bit more than just a high ankle sprain. So now let's talk about high ankle sprains with the syndesmotic sprain. So the syndesmosis is made up of the anterior and posterior inferior tibiofibular ligament. So this is going across the tib-fib joint, the interosseous ligament, and the inferior transverse tibiofibular ligament. So these are the ligaments that stabilize the mortise, and they help hold the fibula into the fibular notch. So anterior to posterior, the talus is wider anteriorly, which requires the distal tibiofibular joint to widen. And so you'll get excessive widening with these people who have a syndesmotic sprain. And we'll look at an x-ray here in a minute, and you can see that widening that occurs. So you got to stabilize that mortise. A lot of times with these, you can just put them in a walking boot, treat them non-surgically, and they do real well. Realize that whenever you get a syndesmotic sprain, This requires a long time to recover. You're probably looking at 6 to 8 weeks. So in a football season, you're looking at missing the bulk of a season with one of these. And one reason is because of the shape of that talus. Because as you're running and you're transmitting your load over your foot, you're now forcing the foot into dorsiflexion, and you're powerfully having to cause that mortise to spread apart. So they can be stabilized surgically. They can put in a cortical screw which goes across the joint, but realize with that cortical screw it doesn't allow that widening to occur because that's natural. So it has to separate, the fib has to separate just a little bit to allow that wider anterior talus to rotate up into the ankle mortise. So if you put a cortical screw in there, you're going to have to take it out at some point because it won't allow the normal motion to occur, and you lose that 10 degrees of dorsiflexion that you have to have. So they can use K-wire, or you can use a surgical fixation with a loop that goes across the tib and fib. These don't have to be removed. So here's a picture of the mortise, how you see that separation there. So you see how on the right side, this one's been fixated there with the sutures going across the joint, and they have a little button on each side that helps to hold it down. That's pulling that fibula in. Here's a picture of the syndesmotic screws, and again, these are going to have to be removed to allow that ankle to move. But you can see that widening that has occurred there at the mortise, so that ankle is really unstable and has to be fixated to return to normal function. You've probably heard the term Lisfranc fracture. So this is a disruption between the articulation of the medial cuneiform and the base of the second metatarsal. So the mechanism of injury is an axial loading through the hyperplantar flexed forefoot. These typically will result from an MVA, muscular motor vehicle accident, falls from a height, or athletic injuries. Usually if somebody falls on the foot, but you do hear somebody planted real hard, stuck their foot in the ground, and ended up with one of these fractures. They're pretty rare. They only account for 0.2% of all fractures. They will present with pain and edema on the medial plantar surface of the midfoot. If this is unstable, the tarsometatarsal joints will sublux dorsally. So if you dorsiflex the metatarsal heads while stabilizing the midfoot, you can make this joint sublux dorsally. If it's real unstable, you can sublux it medially and laterally as well. You can provoke pain with foot pronation and forefoot abduction, putting pressure across that joint, and it'll kind of hinge open, think kind of like an MCL would. So instability requires surgical intervention. You can treat it conservatively if the joints are stable and there's no widening on the x-ray. So here's a couple of shots. So you see what's normal. See how the bones kind of are jammed in there together. Those four bones are in pretty close congruity. But with this, you get that widening here between the first and second and the cuneiform there. Here's a fluoroscopic view once they've stabilized that. So they're stabilizing this joint as well as this joint across here. Now let's talk about tibial stress syndrome. You probably have heard this referred to as more commonly as shin splints. Shin splints is kind of a junk term. It doesn't really describe exactly what's going on. So these occur in 10 to 15% of running injuries, and they account for 60% of leg pain syndromes, especially with runners. So our risk factors are decreased shock absorption. So maybe somebody's doing all their road work on the road, on asphalt, on the sidewalk, on concrete. Maybe you have a terrible track like we did prior to this last summer. It could be just in training errors, sudden increases in training intensity or duration. Maybe somebody goes from just running a couple of miles to now they try to run closer to 10 miles in one outing. You can get this. Anybody that's running greater than 20 miles per week, which that's a lot of our runners right there. And if you're doing heel training early in the season, this has been identified as a causative factor. And then if you have a history of previous lower extremity injuries, if you have overpronation or increased tibial internal rotation. So most commonly we see this posterior medial, which involves the posterior tibialis, possibly the soleus. So this is traction peristatitis. Did I say that right? Periosteitis? Yeah. So what that's doing is, so you look here, here's the posterior tib on the medial side. So it wraps around the underneath side of the foot and attaches to the navicular and kind of fans out there with some other attachments. So as the foot, if the foot overly pronates here, now you're taking that posterior tib tendon and you're just collapsing it down and putting a lot of traction across the muscle in that tendon. You can get these anterior lateral with the anterior tibialis on the tibia and possible involvement in the interosseous membrane. So here's just a little algorithm for treating these. So sorry that's a little bit blurry. So medial tibial stress syndrome, they'll present with dull aching pain, typically on the medial side of the tibia. They'll have diffuse pain over the medial border of the tibia, so you just kind of run your finger along the back side of that tibia and you'll feel, a lot of times you'll have kind of some crunching there and you'll have some soft tissue dysfunction going on there. They'll probably hyperpronate whenever they walk or run. Again, x-ray is not going to show too much. They may have kind of an irregular border along the medial tibia. And here's some other things that you can just look over. Perineal nerve entrapment, and so you can differentially diagnose these. Chronic exertional compartment syndrome, and then your tibial stress fracture. So you can look at those and see the differences and what you may be looking at. You don't really need to know all of these other three. Just FYI, so you know what you're looking at. So if you happen to see chronic exertional compartment syndrome, you don't get it mixed up with medial tibial stress, because you can get kind of some similar symptoms, but they are very different in how you treat them. So let's discuss some rehab tips. So a lot of times just a regular ankle inversion sprain. I didn't cover it here. I figure that's something that you've covered a lot through your other classes. So an inversion sprain has a pretty high recurrence rate. At least about a third will recur. So if these continue to recur, you end up with instability of the ankle. Instability of any joint is going to lead to early osteoarthritis. So our goal with somebody that has an ankle inversion sprain is for them not to have a recurrence within a year. So we want to get them out of that first year, because if you start having multiple sprains during the same year, then you're really going to set these people up for instability. So it's really important that we do a good job of rehabilitating these, that we get them all the way back through return to play. That we don't just, you're good enough to run, and even though you may not be running real good, let's just tape it up and see what happens. We really need to make sure that we're doing a good job of rehabbing these. And they're so common that a lot of times our athletes don't take them as serious as they should. So we need to instill and ingrain in them the importance of making sure that we see it through. So if you have somebody that has an ankle sprain and they don't go back to playing the same game or in the same practice, doesn't necessarily mean they have a terrible ankle sprain. But if they go back and they do return to play or practice, then it probably means that they don't have a terrible ankle sprain. So typically a grade 2 or a grade 3 is not going to be able to go back into playing or practicing. Grade 1, yeah, you can go back and play with those. Sometimes an athlete may not, though. But if you have somebody that came in, hey, you sprained your ankle in this game, did you finish? Yes, I finished the game. Then you're thinking in your mind, it's probably not a grade 2, probably not a grade 3. So one little quick sideline evaluation that I like to do is have them do 10 single leg heel raises. If they can do that with pretty close to the same amplitude as the opposite side, then and with minimal pain, I'll have them do 10 single leg hops. If they can do those two things, then they're probably got a pretty good chance of going back in and playing. So with ankle sprains, with ankle surgeries, early weight bearing and range of motion is real important, as long as it's not contraindicated by your physician. So if you have a surgery and they have them non-weight bearing, if they have them in a cast, there's not much we can do about it. So early normalization of gait pattern is really key for the ankle. As soon as we can return those normal mechanics, the quicker they're going to be able to return to play. So you can't run if you can't walk, is kind of my point of view on that. And so most of my ankle sprains, I usually don't put them in a boot. Here, I'm a little bit more quickly to put them in a boot, just thinking of they have to get around campus. So a lot of walking like that, especially if they're limping, they have an antalgic gait pattern. I would rather them walk more normal with a boot or walk more normal with a single crutch or with two crutches than to have them hop around and hobble around all over campus. So we need to focus on foot intrinsic musculature, especially this is important after non-weight bearing or immobilization. So if they're even in a walking boot, their foot's not having to adapt to the surface underneath because it's not changing in that walking boot. So it's really important that we get the foot intrinsic muscles involved. This is something that easily gets overlooked and gets passed over. And then, of course, we do a lot of proprioceptive activities with ankles, and that's really important, especially to prevent recurrence, because as we talked about a minute ago, you look at the structure of the foot, the way the ankles are, it's real easy for us to invert and to roll over that. So if we don't have a good feel, if we don't give our athletes a good feel of that ankle getting in a bad position and being able to use the muscles to get you out of that bad position, then you're setting your athlete up to fail. Talk quickly about orthotics. There's three basic types: rigid, soft, and semi-rigid. So rigid is going to give you more control. A lot of athletes don't like the rigid orthotics. You have to get a really good fit on these. For a rigid orthotic, you really need to get one that's a custom fit. A soft or accommodative orthotic doesn't really correct the mechanics, but it gives you some cushion or shock absorption. It's really not trying to alter the foot position. And then semi-rigid integrates a rigid orthotic with a softer accommodative material. It provides alignment, reduces shock, and it provides some stability and support. So if these are typically the ones that we go into because, again, a rigid one gives too much control. It's almost like sticking a rock in somebody's shoe, whereas a semi-rigid, it's somewhat accommodative, so they tend to do better with that. If you have an athlete with a rigid foot, orthotics typically don't seem to do as well with them as if you've got somebody that has functional supination. If you look at their foot in a non-weight bearing position and they have a nice arch, but as soon as you put it on the ground, it flattens out, those are the people that are going to do well with an orthotic. But if you look at them in a non-weight bearing position, their foot's flat and rigid, and you put them on the ground and they're still flat and rigid, orthotics aren't going to do much for these folks. Now let's talk a bit about footwear. So we have different types of last, and you kind of want to match this to your foot type. So if you've got a really flat foot, you're going to need a really straight shoe, because if your foot looks like this, then you've got to put it in a shoe like this, because if you try to take that flat foot and put it into a curved last shoe, then their foot's trying to go this way, the shoe's trying to go that way, so that doesn't work real well. Then you see the semi-curved, so somebody has a bit of pronation, but they're a little bit more supinated, so they're kind of in the middle of the road. So you probably want them to be more into a curved shoe. And then lastly, somebody that supinates is going to want more of a curved last. So you can pick up a shoe, just look at the bottom, and you can see the difference in these 3 running shoes. So you want to match that up to your foot type. And we'll talk about this in lab. Just an easy way that you can assess a shoe. You can look at the heel counter. So the heel counter helps to support and control the rear foot. So it's controlling the calcaneus. So remember and it's controlling the subtalar joint. So remember how the influence of the subtalar joint on pronation and supination. So we want a shoe with a nice firm heel counter that control that. And then just the breaking point of the shoe. Where does it, if you just squeeze it, does it break in the middle or does it break out towards the toes? We want it to break out towards the toes and not in the middle. And then lastly, you can take out the insole of the shoe and you can look at the stitching of the last, and you'll have a board last where the stitching is around the outside. So if you have somebody that needs stability, that's what you want to see. If you have somebody that requires less stability, you'll see the stitching down the middle, or you may have a combination of both. So we'll take a look at that in lab. And that's our lecture for today. Hope you enjoyed it. We'll see you in class.